Good evening, Sandeep sir.
Sir, good evening.
Sir, you are on mute. Sandeep sir.
गुड इव्हनिंग चेतन. गुड इव्हनिंग ओंकार साहेब. काय म्हणताय?
बस मीटिंग झाली, रिव्ह्यू मीटिंग.
हा झाली झाली.
अरे वा, लवकर आटपली.
आता जस्ट संपली.
क्या बात.
फटाफट हे करून टाकलं.
हॉटपॉट स्वीट क्या.
चेतन, इसका बैकग्राउंड कैसे चेंज करते हैं?
सर लेफ्ट साइड में बॉटम में ना जो स्टार्ट वीडियो स्टॉप वीडियो का एक ऑप्शन आ रहा है ना, उसके ऊपर वीडियो के ऊपर एक अप एरो है.
ये है क्या चूज वर्चुअल बैकग्राउंड?
राइट राइट.
वही ऑप्शन है ना?
हाँ हाँ. उस पे से फिर एक इमेज आएगा, वो आप सेलेक्ट करोगे ना तो बैकग्राउंड चेंज हो जाएगा.
वो वीडियो फिल्टर करना है क्या?
सॉरी.
वीडियो फिल्टर पे नहीं जाना है ना?
नहीं नहीं, वो फिल्टर करोगे तो ये कलर चेंज हो जाएगा उसका.
आ गया अभी?
हाँ सर, वीवो वर्ल्ड कप.
लेकिन ये ऐसा ब्लिंक क्यों हो रहा है?
ये सर बैकग्राउंड चेंज करते हैं ना, तो इसमें जूम में यही इशू है. मतलब वो ब्लिंकिंग करता है बीच बीच में, अपना भी फेस वगैरह कट हो जाता है थोड़ा थोड़ा.
दिख रहा है अच्छा?
हाँ सर. या तो एक बार बैकग्राउंड दूसरा चेंज कर लो एक बार आप.
ठीक आहे, दुसरा देखता हूँ एक मिनिट.
चेंज का करायचंय?
हम्म?
चेंज का करायचं बॅकग्राऊंड?
तसंच करून टाकतो ते सेम सेम बॅकग्राउंड वरती.
अच्छा.
एअरपोर्टचा बॅकग्राउंड ठेवूया आपण.
क्या बात. हो. पण साईडला जरा ते दुसरंच जरा ते. हा. आता
असं वाटतं एअरपोर्ट वरती बसतो.
एअरपोर्टला मीटिंग करताय. रात्र एअरपोर्टला, इकडे दिवस.
असं वाटतं एअरपोर्ट वरती बसूनच आता करतोय.
हो.
हा
येतील
चांगला
VT येतील, टायमात येतील सगळे ना डॉक्टर सगळे आता.
आहे, सगळे टायमावर एकदम.
चालेल. ठीक आहे. केस मी करू प्रेझेंट ना आपली तिकडे.
हा, केस फक्त तुम्ही करा प्रेझेंट, रेस्ट आपण.
बरोबर.
सर आले की एकदा विचारू आपण.
ओके.
आणि ते फक्त 2 क्वेश्चन सांगायचे आहेत सरांना.
कोणते?
तेच ACS मध्ये कोविड पेशंट.
हो हो हो, ते काय सांगायचे. हो बरोबर. अजून डिबेट झाली का सर पुण्याची प्लॅन आपली?
झाली झाली.
ओके.
पॅनल सगळे रेडी आले.
अच्छा.
मॉडरेटर करतो आता.
ठीक आहे.
उद्या अपडेट करून टाकू.
चालेल.
नागपूरची पण एक करायची.
हो हो.
आणि रोहितची पण ती 15 तारखेला नाहीये, 22 ला आहे.
22 ला हो ते केलं मी चेंज, ते होईल ते.
आजचे सगळे एकदम पॅनलिस्ट आपले चांगले आहेत.
हो दिग्गज कलाकार आहेत सगळे. एक मिनिट द्या मला.
Hi, sir. Very good evening. Sir, voice is muted.
What time we are going to start?
5, sharp 5
5
will start.
o'clock. So still now 15 minutes more, na? 10 minutes.
Yeah, yeah.
Oh, okay. Okay.
You can be here around. I'll give you a call then. Hi, sir. Very good
Hello.
evening.
Good evening. Good evening.
So welcome. Yeah. So we'll start by 5.
Yeah. No, just trying to check through,
Perfect.
Hmm.
चलो नवनीत.
Hi.
गुड इवनिंग. हाय.
Good evening. Good evening. How are you?
बस मैं ठीक हूँ.
Okay. One second. I just.
Bharat sir, good evening. Hi.
संदीप. गुड इवनिंग. हाय अशोक.
Hi.
Good evening, Ashok sir.
Can you hear me?
Yeah.
वेरी वेल.
Okay. My internet is little slow. I'm on direct line. Hi, Kumar.
Hello.
Hi. How are
Hi.
you,
How are
Kumar?
you, friend? How are you, Ashok? All good?
All well, Kumar?
Yes, all is good. All is good.
Good.
We're starting at 5, no?
Yes, sir. Yes.
Okay.
Dr. Vitisha sir is coming. He's joining.
Yeah.
We'll
Okay.
start.
Don't worry. Let him join.
VT has such a tight schedule. He must be winding up one seminar.
Yeah. Yesterday he told me that he doesn't remember there's a seminar like this today. I said, good.
Very possible.
Yeah.
Sir, आ गए.
Think of the devil.
Yes. Sir, unmute yourself.
अरे आप नाम बदल के क्यों आए हैं VT साहब आज? दियान शाह बन के आए हैं आप आज?
Mute.
हाँ?
Sir,
आपका नाम बदल लिया, नया नाम रख लिया कुछ इस मीटिंग के लिए?
स्क्रीन नेम चेंज हो गया, राजेश खन्ना जैसे हो गया है.
I know.
जस्ट ए सेकंड.
आज की मीटिंग के लिए नया नाम रखा है साहब ने.
नहीं वो क्या है अभी?
क्या है क्या?
That's the name of my grandson actually.
That's the
I
I'm going to
see.
say that only.
Yeah.
Ah.
So VT is getting younger and younger now.
Yeah. So
चलो भाई,
What do you say?
yeah.
बड़ा तकलीफ भी हो.
बिल्कुल बिल्कुल.
So I wish यार. Hi Anil Sharma साहब, कैसे हो?
Good evening, boss. All well. Good evening, everybody.
Good evening, everyone.
Nice to see यार कि बॉम्बे हॉस्पिटल से आपको टाइम मिल रहा है.
नहीं, मेरा तो नॉर्मली 3-4 घंटे काम रहता है 9 to 1 का. बाकी कोई इमरजेंसी आ लगे, बेड ही नहीं मिलते हैं आजकल. प्रॉब्लम क्या है?
अच्छा, वाह.
अच्छा, वो कोविड का चल रहा है.
कोविड के बाद नॉन कोविड में चले जाते हैं ना कोविड वाले.
हाँ.
तो इनफैक्ट वार्ड में एडमिट किए. आज भी 2 पेशेंट है, बेड ही नहीं मिल रहा है. अभी क्या करें? मोस्ट डिफिकल्ट थिंग इज टू बेड नॉन कोविड गेट बेड.
राइट.
सब उनका सांस फूलता रहता है, वो जाते नहीं है, डिस्चार्ज नहीं लेते, वो नॉन कोविड में चले जाते हैं.
हाँ, दिस टाइम the COVID admissions are for a long time. Everybody says so. कोई जाता नहीं जल्दी. और क्या है, they are noticing on the 10th day complications. So nobody wants to discharge before 2 weeks are over.
बिल्कुल सही है.
नहीं तो उसके पहले वर्टिकल डिस्चार्ज हो रहा है ना आजकल.
सही है, वो भी
सही.
That is a bigger problem.
अभी परसों ही हमारे एक वो है टेक्नीशियन, उनकी वाइफ एक्सपायर हुई 50 years. Only just hypertension that was very well controlled, and she was supposed to be shipped out of the ICU that morning. Again, suddenly she became breathless, and after 4 hours she died.
No, listen. The patient reaches ICU, na, that patient survival is very low.
Very difficult.
जब
ये सडन डेथ जो होता है वो अल्टीमेटली फाइनली कार्डियक होता है या
Symbolic.
our patient, नहीं, hypoxia induced refractory bradyarrhythmia and arrest.
Correct.
But is it pulmonary embolism?
No. नहीं. वो just
अरे ऐसा कैसे? कितने लोगों का, वीआईपी लोगों का भी पढ़ रहा हूं मैं. साला अभी अच्छा था, बाद में सडनली ब्रेथलेस हो गया, ब्रैडीअरिथमिया हो गया और मर गया. ऐसा लगा.
If you do
another patient, our staff, cath lab, that assistant technician's father, he was 78. He developed TBA, and after 2 days he expired.
Sir, the other thing is, all these patients, by the time they reach ICU, they are all anticoagulated.
Yeah.
So you know, again, to attribute pulmonary embolism at a terminal event is difficult. Is all this whole.
लेकिन इतना सडन रेस्पिरेटरी कॉज क्या हो सकता है?
अरे वो सर, वो लंग इतना खराब होता है, मैंने क्या नहीं देखा है. तो it just can't cope only. The heart and lung together can't cope. अभी कल रात को ही अपना एक पेशेंट मर गया है. तो IHT 35%, holding out on the floor, and then goes to ICU. Metabolic acidosis, renal shutdown. It's just a vicious cycle.
करेक्ट. नहीं, कल भी एक कोई बड़ा ऑर्थोपेडिक, सीनियर ऑर्थोपेडिक सर्जन ऑफ दिल्ली मर गया. व्हाट्सएप पे घूम रहा था.
4 डॉक्टर एक्सपायर हुए एनसीआर के अंदर कल.
हाँ, वही तो
व्हाट्सएप चल रहा है वो. One practical problem which I faced actually day before yesterday. One patient came with the MI. Now without RT-PCR you can't admit. Other alternative is rapid antigen plus HRCT. Rapid antigen was negative. RT-PCR, then HRCT created some doubt, some shadow. So we had transferred him, admitted in the COVID ward. Fortunately COVID मिल गया. अब अगले दिन RT-PCR रिपीट कराया, वो नेगेटिव है. अब उसको वापस बाहर ले लिया. अब now I am worried कि वो जाने से तो कहीं COVID नहीं ले लेगा वो. But fortunately patient is stable.
You're not doing gene expert.
You don't have to get into all that, Anil. If here,
it is not my role, it is hospital's role.
नहीं, सुनो. If it is a ST elevation now, and you want to do it, you just wear your full PPE and then let them be in the suspect ward, suspect ICU until they decide he is negative or not. अपने को अपना काम करके निकल जाना है.
Patient stabilized with thrombolytic therapy.
So
Admit क्या करना है?
let's begin today's program. Sir,
Okay.
VT,
Yes, sir.
program शुरू कर दो आज का.
Yes, sir. Yes.
चलो ठीक है, चालू करते हैं.
Chetan, just
Mr. Sandeep, can we start now?
yeah. Chetan, just check whether we are live. Just confirm and so that
By the time we finish introduction and all that,
yes,
people
sir,
will
yes.
join by the time we finish introduction.
The entire panel is there, sir. With your kind permission, I will start with the once he confirms. Chetan, just confirm
Sandeep,
once
sir, we are live now.
we are live. Great.
Yes.
So good evening, one and all. I am Sandeep Kamble, DSM representing Alkem for the West Zone. So I welcome you on behalf of Alkem for this August scientific gathering. So on behalf of Alkem, as you all are aware, Alkem is the 5th largest pharmaceutical company. So I welcome today the eminent moderator, the panelists, and all the doctors who have joined us for this today's antithrombolytic debate. So at Alkem, it's always been an endeavor to partner with the healthcare professionals, and we will certainly continue to do so in the coming days. So today, to help us to navigate through this meeting, we have one of the legendary renowned cardiologist from the city of Mumbai, Dr. Vitisha sir, to moderate the today's debate on antithrombolytic panel discussion. So just a quick brief introduction, as sir doesn't require any introduction. He is well known across the city of Mumbai as well as entire West Zone. So sir, I welcome you as a moderator for today's panel discussion. He is a senior interventional cardiologist in the city of Mumbai with a lot of strong academics and almost more than 30 years of clinical experience in the field of cardiology. He has various publications in various reputed journals like JACC, Indian Heart Journal, and also he's associated with all the leading associations like Global Hospital, Wockhardt, Cefi Hospital, British Candy, Surana Setia, Raheja Fortis, and Prince Ali Khan. So I welcome sir on the dais as a moderator for today's panel discussion. I also take an opportunity and pleasure to introduce the legendary panel for today's meeting. We have Dr. Ashok Punjabi sir from Krishna Cardiac Care Center in Dadar. We have Dr. Navneet Kumar sir from Hinduja Hospital. We have Dr. Anil Sharma sir from Bombay Hospital. And we have Dr. Bharat Shivdasani from Jaslok Hospital. So with this introduction, I hand over the session to Dr. Vitisha sir for further proceedings. Thank you so much.
So good evening, everybody. Let me share my screen. And okay. So friends, sorry, just a second. Let me see. Yeah, so is my screen visible?
Yes, sir.
Yeah, and I am audible also.
Audible, visible.
Very good. Thank you. So thanks Alkem to give us all this opportunity. In fact, actually, you just introduced me by 4-5 lines, but did not introduce the other panelists in so many words. In fact, they require maybe 2 or 3 times more lengthy description than what I require. They are all legends in their own way, and everybody has contributed to the field of cardiology in many ways. So let us start with today's program. In fact, it's more of an interactive session, and everybody should chip in their opinions and various possibilities. So our first case for today is a 72-year-old male who has come in emergency department complaining of sudden onset chest pain for last 1 hour. His weight approximately is more than 60 kg. Pain was typical of cardiac origin, smoker, non-diabetic, history of hypertension, on hypertensive drugs controlled, extensive inferior wall MI on ECG with raised cardiobiomarkers and blood pressure stable, 130/70, pulse is stable, and he is ready for a PAMI. So with that, this is his ECG. And as you see here that he has got both inferior, lateral, and possibly posterior infarct also. So either maybe a dominant RCA circ or combined RCA circ lesion, whatever it is. But our main focus of discussion today is about antiplatelet agents and anticoagulation agents. So with this, we would like the opinion of all four of us about what would be their loading antiplatelet regimen instructions to the casualty or to their ICU staff. So let us start with rotation so that, you know, everybody gets a chance for the first time and the last time both. So on my screen, I see Dr. Navneet Kumar next. So let us start with Dr. Navneet Kumar. What's your protocol at Hinduja Hospital?
When patients are ready for PAMI, we normally load them in the emergency room with aspirin, and we give them ticagrelor 180 milligram to begin with. That is our normal regimen. Well, that is what we have been following. And the advantage that we find, because we do not know how the coronary anatomy could be, looking at the ECG that you had projected earlier, we showed the inferior wall MI with secondary changes in the anterior wall leads, with ST being more up in lead 3 than lead 2, it's more likely to be an RCA lesion. Based on the ECG diagnosis, more likely to be an RCA lesion. And as you rightly said, it could be even a dominant circumflex. The lateral wall changes, though not really ST showing up. But then, yes, it could be either a combination. So once you have decided upon doing a primary angioplasty and patient has agreed for it, our first line would be to load him in the emergency room itself. Or sometimes we even load them on the table in case we are not really decided, because ticagrelor acts very fast. Within half an hour, 40 minutes, by the time you're done with your plasty, the effect comes through. But as a protocol, we are normally loading them in the emergency. The other thing what we find, suppose if this patient does not agree for angioplasty for any reason, suppose if he turns out to have multi-vessel disease or something which you feel is not a good anatomy for doing an angioplasty and you're sending for a bypass surgery, you have the advantage of ticagrelor being a reversible agent. Within 48 hours, probably you can send them for a bypass surgery as well. So our regimen has been only to put them on ticagrelor rather than putting them on prasugrel, though the data has been kind of saying that yes, prasugrel works better in certain settings.
Yeah, excellent reasoning for giving Tika as a loading dose. Bharat, your take now at Jaslok?
Yeah, I think we also, patient is ready for a procedure, same protocol. In case for any reason right at the outset, patient is not keen for whatever reason, financial or otherwise, for any intervention, then is a question of medical management. There you have the option, either you use ticagrelor or you can use 600 milligrams of clopidogrel. Again, even for medical management, ticagrelor in acute coronary syndrome fares better than clopidogrel in terms of data. So you'll tend to move towards ticagrelor in any case. So this is as per the loading, and I think now option of 300 milligrams as loading should be removed, because the Armida trial and the data clearly shows that loading with 600 of clopidogrel is far superior than only 300. So that shouldn't be an option unless for some reason that the patient was thrombolized outside, then it's a different situation.
Right. So Dr. Anil Sharma, your take on this?
I do same thing at Bombay Hospital. Aspirin, non-entry coated loading dose, and ticagrelor 180 milligram. But for theoretical discussion sake, this patient is less than 75, weight more than 60 kg, no TIA, so prasugrel can also be used. So acute coronary syndrome, ticagrelor and prasugrel are preferred over clopidogrel. if patient does not require or don't want CABG or cannot be done, then medical management also, as Dr. Bharat also said, medical management also ticagrelor can be given. Prasugrel is superior little bit as compared as per ESC guideline as compared to ticagrelor in post-MI patients. But only caveat is that if until unless we know the anatomy, prasugrel is not the preferred drug.
So actually it should not be given as loading in the casualty or
Yeah.
in the ICU.
Yes.
Right. So unless you do an angio and then you decide to do a PAMI and then you can give prasugrel. So prasugrel option, even in recommendations, they say that
Yes.
only after the anatomy is known. The other problem with prasugrel is the 6 tablets, 10 milligram into 6. And
Yes.
then you give a 300 milligram aspirin and a statin. So the loading is too much psychologically for the patient. And Dr. Punjabi, your take on this? Suppose if he comes in your ICCU nursing home setup, what would be your take?
Well, when there is a doubt as to whether he'll be ready for the angioplasty or not, then we load them with clopidogrel 300 milligram and mobilize the patient, get them to the hospital, and after doing the angiography shoot, we give them an additional 300 milligram of clopidogrel. Or when it is very clear cut that he is ready, absolutely ready for the angioplasty, we load them straight away with ticagrelor 180 milligram.
Right. So that's a nice point actually, Bharat. This also, you quoted Armida trial, right? But in Armida trial, 600 milligram, everybody went for intervention. This 300 milligram dose specifically is for those patients who do not go for intervention, and if you are going to thrombolize those patients.
Yes, correct. That is the sort
And-
of
And if
separation
they go,
that I
as Dr. Punjabi said, if they go for intervention, you can always give additional 300 milligram, or you can give 2 tablets of Tika after the stenting is done.
correct.
Right. So that's a good point.
But-
And the other thing is, I just wanted everybody's opinion whether crushed tablet of Tika would be better than giving just 2 full tablets. What is your take on that?
I think, now, to be honest, whether Tika or whatever, the crushing seems to be favorable.
Right. And as you all know, this concept of crushing came. Why? Because in UK, they had this protocol of giving morphine to all their patients, even when they are in the ambulance. And they found out that the absorption of Tika was delayed because of that when they were giving these 2 full tablets. So now everybody says crush it and give it, absorption is faster, and maybe that is good.
No, but even on practical basis, see, patients are in so much of discomfort. They are lying down. To swallow so many tablets on top, aap statin dete ho, multiple tablets. So crushed form is also easier for them to ingest, I feel.
Correct, right. And just a theoretical question. In case this patient is in atrial fibrillation, then what would be your take, all of you? Suppose if he has got AFib and he presents with the same scenario, so what would be your loading choice then?
Yeah, I think then it's clopidogrel. Based on the Augustus trial, you would probably like to give clopidogrel rather than giving ticagrelor, because if you see, only 8 to 9% of patients in that trial had received ticagrelor, and of course the bleeding was not reported to be much higher in those, but the number was too small to say anything, and the trial has been done with clopidogrel, and the data is mainly on that. Viti, I would want to bring one more point. Suppose if your patient has got a lung issue or an asthma, and you're seeing him with this kind of thing, then how would you go around? Would you really go for prasugrel at that stage or clopidogrel? I would want an opinion from the panelists.
Okay, fine. Come on now. Let's say rest of them, and I'll tell you what my opinion is. Let us start with Anil. Anil,
Just address that issue as well.
yeah,
I
Anil,
ask-
you start this
see,
this debate. Yeah.
This ticagrelor issue, as far as breathlessness is concerned, I think it is nothing to do with the bronchospasm. So I don't make my view change. I give all patients. Only thing is, when heart rate is less than 50, then I'm little more concerned about, because if patient is having some kind like inferior MI, if some bradycardia is there or some pauses may be there, that though rare, but that may be the issue. But as far as asthma is concerned, I will give ticagrelor.
Very good. Dr. Punjabi, your take?
I don't think we should make any difference between an asthmatic and a non-asthmatic as far as use of ticagrelor is concerned. You can safely use it.
Right. Bharat?
So I agree with what Anil said here. At least in this case, though, heart rate is in sinus and 70 per minute, so you're safe. Other area is that if your patient is CKD with a very low stage 4 or stage 5, then there I would again prefer clopidogrel.
Exactly. So Bharat, you answered actually my next question was, if this patient's creatinine was 2.5, what would you do?
Yeah.
Suppose if it is more than 2.5, his creatinine, then what would be your choice?
Yeah, correct. So there, or if patient is on dialysis or creatinine, like you said, 2.53, then I am very comfortable and I prefer to go with clopidogrel rather than, ticagrelor or others.
Right. So, and the other thing about Tika is, this symptom of breathlessness. If you see the studies and the trial, the maximum reporting is on the 5th to the 7th day. So it's not that you give 2 tablets loading and immediately patient complains of breathlessness. So we can tide over our initial 3-4 days of our stenting period or immediate period, and then in case if he does complain and if it is too much of a problem, you can still shift to either prasugrel or clopidogrel. Dr. Navneet Kumar, you have some specific point in this, or your different experience?
No. I have a point here to make. What you all say is practically correct, theoretically correct. But see, what happens sometimes, the problem arises that your patient, when you say is little breathless, he may be in mild failure. Now he starts complaining of some dyspnea. Then again, you are confused. So if that is a situation, is this really important to have them on ticagrelor, or why not use prasugrel if there is no contraindication for using prasugrel? You can just give them on the table, like, it all depends when you are first examining them in the ER, that's important. And when you talk about this pauses part, of course, that is known to happen more often, but even clopidogrel is known to cause pauses. If you see, the pauses are also seen with clopidogrel. It's not only with the ticagrelor that you are seeing some pauses happening. And quite often, these patients with inferior wall MI, because of the MI situation, they land up with blocks. So if the patient, let's say, has got a heart block or a high-grade AV block, would you refrain from using ticagrelor in such patients, or you would just put in a temporary wire and go ahead with your procedure?
No, I think if the temporary wire you're going to put in, then there is no reason to be afraid of any pauses or anything like that.
So I don't think that should be an absolute contraindication to kind of say that you're not going to give ticagrelor because the patient has got a bradycardia, because bradycardia is expected with inferior wall MI. In the proximal RCA lesions, particularly if a patient has got an RV infarct, or you would normally find these patients are a little on the brady side, and that I don't think should be a major concern. You can always have a standby wire. Now the thing is that dyspnea related to ticagrelor is normally supposed to pass off in about 3 weeks' time. But that period in between where your LV functions are compromised, the dilemma arises whether these patients have got failure-induced dyspnea, because it becomes problematic quite a few times. And you see the withdrawal rate with the dyspnea-like symptom has been around 20 to 23%,
I agree, Dr. Navneet Kumar, that in certain situations where breathlessness becomes a predominant feature, either coexisting asthma or failure, then it becomes very difficult to judge every time patient calling you, dum lagta hai, and then you say, get this headache rid off and please trip to.
I'm talking of an ICU situation as well. On the 3rd day, 2nd day, 3rd day.
Yeah, right.
And second, suppose now if you decided to switch over to another compound, let's say clopidogrel or prasugrel, would you give a repeat loading dose or would just carry forward with the normal dose? My another question.
Good, excellent. So let us get the opinion, Dr. Punjabi.
I think you will need a loading dose at the next due dose, which is for the ticagrelor due. At that time, you would load the patient with a.
Right, Bharat?
Yeah, so at the next scheduled dose, you give the loading, Only thing is, if you want to reload with say you're on ticagrelor and you want to go to clopidogrel, then you don't necessarily have to give 600. You can give 300 instead at that time, because you've already achieved with ticagrelor, you have already achieved almost close to 80% of platelet inhibition. So that much is sufficient. And if you are worried about bleeding for any reason, then you're loading with prasugrel. You can give either 3 tablets and then the next dose you can give 3. That is an option to you. But preferably at the next dose, load with the recommended dosage.
Right, right. Dr. Sharma, your take?
Yeah, clearly it is a clear recommendation from ESC that if you are going from weaker to stronger medication, you require the loading. But if you are going from stronger to weaker like clopidogrel, then there is no need to go for loading.
Right. I think you can shift to clopidogrel even 75 milligram also. So in that sense, now the question sometimes arises is that, you know, patients are seen in some nursing home. They are already given clopidogrel either 300 or 600 and loading aspirin, and then they come to the hospital for intervention. So what do? Do you give them either 2 tablets of tica or 6 of prasugrel then, or after the intervention, or next day 24 hours?
No, if it is coming from weaker to like clopidogrel to if it is a prasugrel or if it is a ticagrelor, definitely with the next time of the next dose, we have to give the bolus. So that is usually at the time of the procedure.
No, I think Anil, what he's asking is that they have shifted from a
So patient is already on clopidogrel. If we have to move on to the other procedure, that is, I think I am going to ask one question that will make it clear, I think. See, now patient already received clopidogrel. I would prefer to now do angiography itself. I will not give any bolus doses now. And depending on that, because if it is a MI patient, prasugrel was preferred over ticagrelor. So now I will see the anatomy. If anatomy wise it is a medical management, then I will switch over to the ticagrelor. If it is angioplasty, then prasugrel is better than ticagrelor in post-MI patients. So I would give the bolus after angiography. Those already who have received thrombolytic and clopidogrel, all these things.
Dr. Anil,
I have
a question here for Dr. Anil Sharma. I think it would be important to see if the patient has received thrombolytic outside or not, because whether the patient first went to the nursing home, maybe you would like to say that don't delay the treatment, because it may take time for the patient to travel, and by the time patient is on your table, this patient could have been thrombolized. I think so we'll have to differentiate the subsets who are thrombolized vis-a-vis who are not thrombolized. Let's talk of a non-thrombolized patient as what we are discussing now. Now,
that's my one small question, sir. Then we'll discuss. So now, how many times you have taken patient like post-thrombolytic therapy or PAMI, like pharmacoinvasive, or it is PAMI, you have taken patient on the table, and how many times you have come out without doing angioplasty and sent patient for CABG or primary immediate surgery or maybe medical management?
Yeah.
How many times?
Most of the times they have been subjected to angioplasty. Facilitated PCI we have been doing very often, particularly today in this COVID era. What has been happening most often is being facilitated PCI, where they've been thrombolized followed by this. See, as far as upgrading the agent is concerned, I totally agree with you when you say know the anatomy and give it. So if the patient has been loaded with 600 milligrams of clopidogrel, we normally proceed with the procedure. And then when the next dose is due, we give them a full dose of ticagrelor. And as what you say, if your choice is prasugrel, I totally agree. You know the anatomy, after anatomy, you can decide what you want to do.
So you want
I would also agree that once 600 milligram is given,
No, not both.
600 milligram is given, let the life of that 600 get over in the next 24 hours, and then give the loading of whatever other drug you want, tika or prasu.
Correct.
That would be ideal. Otherwise, maybe the bleeding tendency would be much more.
Yes. So after clopidogrel bolus, do first the angiography and then decide whatever bolus to be there. Don't just give all the patient who are already on clopidogrel and then just give the 2 ticagrelor and then maybe switching to prasugrel, that will be too much.
No, we're not talking of that. Dr. Anish Sharma, you got us wrong. What we are trying to say, once the patient has been loaded with 600 milligram, you can even proceed with the angioplasty with say 600 milligram clopidogrel. At the next due dose,
Yes,
you can decide
next-
to switch over
next
either
dose.
to Tica or prasugrel. Or if on the table, you feel that after giving 600 clopidogrel, you would want to give, after knowing the anatomy, immediately prasugrel is the question. Whether you would give it immediately or you will give it in the next 12 hours when the next dose is due. If he has received 300, probably I would not hesitate giving on the table also.
Yes,
but if
yes.
he has received 600, I'll be a little reluctant for the care of bleed. That is my take.
Yeah, agreed. Absolutely. I think
Absolutely.
we should follow that regimen that if 600 is given, give the next bolus when it is due for the next time, rather than, especially if the patient is like 72-year-old, as in this case, then we would not like to take chances, right? Now, the last question on this issue is, suppose in this COVID era, the fellow's platelet count is less than 1 lakh. Then what would you choose?
I think platelet less than 1 lakh doesn't make it with the count unless it is very severe.
So
If it is less than 20,000, then maybe
the safety comes when platelet count goes less than 50,000.
Yeah.
So even if it is 1 lakh, even if it is 75, you can begin with the doses, and then you will have to decide to what level the platelet count drops, and then whether you want to keep on dual platelet or single platelet.
But if you have stented, you want to still think, okay, anyway, by the way, you see in Plateau trial, the cutoff was 90,000. Less than 90,000 was the exclusion criteria.
80, 90, correct.
Yeah. So I think we should stick to it because we do not know.
we should not extrapolate.
Yeah. So then in that sense,
See,
whatever would be.
it's like this, VT,
Yeah.
that these are the newer P2Y12, the ticagrelor and prasugrel, they are more potent and the bleeding tendency naturally is higher. So where there is a doubt about the platelet count, then you already have one criteria from the Plato, then you rather use clopidogrel instead.
Absolutely, you are right. So that's what I was coming to. So in that situation, to be on safer side, it is better to use clopidogrel, even if the patient is COVID positive.
But no, there is data in COVID that if your platelet count is okay, 1 lakh and above, ticagrelor is advocated.
No, the question is when the patient has to be given prophylactic anticoagulant along with all these dual antiplatelet agents.
Yeah, triple therapy.
Yeah, triple therapy, especially D-dimer raised, IL-6 raised, and high chance of thrombotic venous thromboembolism. So there people generally start this anticoagulant.
No,
prophylactic.
see the prophylactic dose, their recommendation, Navneet and I have done that. So it's actually only 0.4 once a day of
Enoxaparin.
enoxaparin. I mean, it's not to be used as in therapeutic, weight related.
Or else oral Revroxaban 10 milligram or Epixaban 2.5.
Yeah, but that again is more towards when they are going for discharge. All in hospital patient, especially in ICU, there is no recommendation for oral. It has to be injectable, either LMWH, or if some procedure is planned, then it has to be heparin in terms of reversal. Anyway, I think we should do that.
I think we will go to our next interesting session. So that's on, wait a minute. Okay. There was only one question which I missed. In large thrombus burden, in case there is need for IC thrombolysis or 2B3A, then better to give clopidogrel. Okay. Anyway, so now this is about dabigatran versus rivaroxaban. This is a 55-year-old female presented in OPD with history of palpitation 2 days back. And 1 second. Yeah. Okay. Yeah. And lasted for approximate 15 minutes. Similar episode she experienced 3 months back. Medical history of hypertension on telmisartan, but not taking regularly. No history of diabetes, no history of CVD, and no history of any major surgery or no history of TIA or CVA in the past. Upper middle class family, vegetarian dietary habits, not on antiplatelets or anticoagulants, CBC normal, renal and hepatic functions are normal, thyroid functions normal, ECG at rest normal, and Holter shows 2D echo shows normal valves. Unfortunately, LA size or LA volume or volume index or velocity not given here, but sorry, why this is not moving? I think I have to. And the Holter showed short episodes of atrial fibrillation lasting for 10-15 minutes. That was the somehow this got hang up. Wait a minute. Okay. Yeah. So, right. So clinical examination normal 122/84, 78 pulse, and Holter report showed short run of AF approximately 10 minutes. So the question was, should we start oral anticoagulant in this patient or not? And if yes, which one? How long to continue and other points. So first let us start with this question, whether she requires anticoagulation or not. So this is the story again. So let's start with Dr. Ashok Punjabi this time. Ashok,
Yes.
what is your take on this?
First step would be to do a Chadwick score,
Yes.
calculate the score, confirm that the score is significant, more than 2 for a female, and certainly she will require anticoagulation.
Yeah,
And we
so
can-
basically she is female and hypertensive, so it makes 2.
2 already here.
Yes, the only question is on Holter, they say that it showed a short run of AF, approximately 10 minutes. So is that sufficient for you to start
Yes.
anticoagulation?
Yes, it is sufficient. Whether paroxysmal or persistent atrial fibrillation, both of them behave the same as far as the risk of thromboembolism is concerned, and therefore you must treat them with anticoagulants.
Right, exactly. So let's see.
I have a different thought.
Yeah, tell me.
So soft point, because 1 minute, her age is 55.
Yeah,
So by age she does not get, except for female sex and hypertension.
right.
So 2 marks and 2 marks for a female. Still, your recommendation will be class 2A, probably 2AB or
So
something.
2B.
So,
Okay.
2A.
so it's not a class 1 recommendation.
Not a
So
Wait
if
a minute, webinar
if this is
call.
my patient at 55 year
मैंने webinar call उनका पेश करें मीडिया को मैं देखता बताता हूँ बाद में.
and without any prior antiarrhythmic treatment, I would not anticoagulate her at this time.
Okay. So, yeah, see, it would be a bit
You can see
debatable. Correct.
VT,
Maybe you will give beta blockers or some rate
yeah,
controlling drug.
because here, see, let's look at it like this. If it was a dilated left atrium,
Absolutely. That's what I was coming to.
if the LA volume index is high, and you know that this lady is then likely to, lapse into this frequently, then I would go for anticoagulation. On the clinical background you have given, good LV, the valve is proper, there is no MR. We have to assume if the LA size is normal, I would give her a good antiarrhythmic, recheck the Holter later, and decide after that.
Dr. Anil Sharma.
So I also miss little bit agree with Dr. Bharat, but I would say this the case I will start with the etiologies. Miss young lady, hypertension, very well controlled with irregular medication. But it may be just anxiety, it may be white coat hypertension. So first establish the diagnosis of hypertension. Second thing, as far as this atrial fibrillation is concerned, by definition, it has to be more than 30 seconds. That is okay. But then again, it is a asymptomatic or symptomatic clinical, or it may be subclinical. So whether this palpitation at the time of atrial fibrillation, that it is maybe correlating. So there are so many things have to be established that it is a definite hypertensive patient which require antihypertensive. There is a no reversible, maybe possibly she had some anxiety or maybe some quarrel at home, maybe some alcohol, and then one episode or maybe two history like this. It is very difficult, and plus low, middle class family, it is a costly thing for lifelong. I will think twice or thrice before starting and discuss with the patient.
Dr. Navneet Kumar.
Yes, a couple of points. I've heard all of them. See, if you go by absolute theoretical indications, what you see, Chadwick score of more than 2 in a female. Indication not very strong, but yes, theoretically it points out to giving them NOACs and putting them on treatment. The most important question that arises is that this patient is young and it's going to be a lifelong therapy. You can't say I'm giving for a few days and stop it. And so it has to be decided the cost of therapy, the compliance of the patient. And when patients are not really symptomatic, they will not be really compliant with this kind of treatment. And the cost benefit ratio again has to be looked into. And as Dr. Bharat said, that he would probably like to treat the atrial fibrillation first. And as you rightly said, you don't have a data on the echo findings. You don't know the size of LE. You don't know how the recurrence is going to be. You are not sure the electrolytes, whether it's an electrolyte imbalance related, whether it's a thyroid related. You know, there are certain other things which need to be evaluated. As far as hypertension is concerned, the slide that you have projected is, we assume that she's a hypertensive because she's taking telmisartan 40 milligrams. Maybe you can switch them to beta blocker. And I would not be too keen on putting them on antiarrhythmics for that matter, something like amiodarone to control that. Again, another toxic drug, lot of side effects and long-term management. So I think the other factors need to be looked into. And you have to define the risk profile. And Dr. Ashok Punjabi rightly said, whether you have a newly diagnosed paroxysmal atrial fibrillation or you have persistent permanent atrial fibrillation, the risk of stroke remains the same in both. So it's like a catch-22 situation where depending on the individual and the type of thing that other parameters that really make you decide, I would say, as you said, it's a class 2A to B indication, not a strong indication. In my clinical practice, practically, if you ask me, I will also be a little reluctant to start them on treatment. Because I will find that patient.
Now, Bharat, I have a question for you.
We twist this a little bit and keep the age, and maybe she's
65, 65 plus.
65 plus.
Yes,
Okay.
so 65 plus, or if we find that, you know, there was a MVP with mitral regurgitation and she's got a dilated LA, let us take that clinical scenario. Okay.
No, so for all practical purpose, let us say that we decide that the patient does require a anticoagulation.
Yes, correct.
Let us say that patient landed with an AFib when you saw the patient.
Yeah.
So then in that situation, age of the patient, we said for a female 65 is the cutoff. So we discussed that part of it. Cost of therapy also, Dr. Navneet Kumar addressed that, whether, of course, now dabigatran and rivaroxaban both are generic available. So I think we can debate as to what, how would you decide upon one of the two drugs? Let us take the opinion of all of them. First of all, we all agree that in today's age, VKAs are not the first choice of treatment at all, unless the patient has a metallic valve or something like that, right? So we will only debate about the choice between dabigatran and rivaroxaban, unless somebody wants to pitch in apixaban also. So let us start with Dr. Anil Sharma now.
Again, as a younger patient, I think best would be the Dabigatran 150 milligram BD, the most effective and mortality reduction. And second choice will be Apixaban. Definitely Rivaroxaban I would not use. Only thing with the Dabigatran is that it may cause little GI bleeding and maybe some increased case of MI, but that was in the non-Asian patients. Later studies in Asian showed that in Asian patients, even GI bleed and MI incidence was also not very high. So Dabigatran is a powerful agent. First option, second Apixaban.
Okay, good. Bharat?
Yeah, I agree. Young patient, primarily the most effective ischemic stroke prevention is with, of all the agents, is with 150 milligram of Dabigatran. And that should not be forgotten because that is the primary aim of our treatment.
Right,
So
right.
that would be my first choice. And if for some reason patient is unable to tolerate that drug or lands up with an event on that drug or with a side effect of that drug, then I will use the other NOAC.
Okay, so Dr. Navneet Kumar?
Yeah, I mean, I will address this question in a little different manner. I mean, I don't disagree with any one of you, what you're saying. My point is, like, as Bharat said, it has to be 150 milligram. 110 milligram dose has shown to be kind of non-inferior, not superior. So if you are trying to give a prophylaxis, it has to be a proper dose of 150 milligram given BID. The other important thing we need to also discuss with the patient, whether they would be compliant or not, would they be happy taking a single dose or double dose, like twice a day? Because many times the compliance is an issue and patients prefer to have a single dose. In that case, the Rivaroxaban stands out. Again, the other important thing would be look at the creatinine, the renal parameters, and how your creatinine clearances is. So you have to look at other parameters. If all are static and similar, that means you are dealing with a patient with PAR, they have a good renal function, they are going to be compliant, they're going to be taking the medicine as you really advise them, then definitely I would be going for 150 milligrams of Dabigatran as compared to Rivaroxaban. And Apixaban would not also be will be my choice. I won't say that I would completely discard it. I would keep Rivaroxaban on the third. So it would go like Dabigatran, Apixaban, and maybe Rivaroxaban.
Right, right. Dr. Punjabi, your take?
I agree fully with Dr. Kumar. In the same sequence, I would prefer Dabigatran 150 BD. If not that, then Apixaban 5 milligram BID. And if there is a renal insufficiency, prefer Apixaban over Dabigatran and Rivaroxaban. And if the patient insists on once a day, then I stick to Rivaroxaban 20 milligram daily.
See,
Yeah.
I would also put on the patient on beta blockers, hoping that the beta blockers may take care of the arrhythmias, may take care of the atrial fibrillation, repeat the Holter after maybe a month or so. And if you see that there is no arrhythmias any further, you can consider getting off the anticoagulants rather than take it lifelong if there are no further episodes of atrial fibrillation. There are quite a lot of few young patients who show episodic atrial fibrillation, and you monitor them over a period of time, you realize that on Holter, they no more have atrial fibrillation. After a month or two, once you are confident, you may even consider getting out of it.
See,
Well, so
there is a fair proportion of patients who are quite well read and quite aware. And if they ask you in terms of availability of antidote, then again, Dabigatran, you tend to sort of weigh in on that. So that is another point.
yeah, availability of that. Right. So first of all, we agree that if at all it has to be given, it is 150 milligram BID of Dabigatran to give the benefit, the superiority benefit of Dabigatran. Apixaban 5 milligram BID also would fit in, except that the cost factor, one. Now, as against single day dose and double day dose, if you see actually both the companies, they argue the single day dose, people say that, okay, it is very convenient, so compliance is good. The double dose, people say that, see, even if you miss one dose, then the other dose is there. So you're not skipping it for 24 hours. So I don't know, but finally, I think patient has to be given a choice, as Dr. Navneet Kumar said, and decided. As far as drug or drug food interaction is considered, anything you want to say on this regarding dabigatran versus rivaroxaban versus apixaban. Of course, the VKs are out. We all know that it has got a lot of food interactions and other enzyme interactions. So let us discuss this point because this we skipped on the earlier discussion. So let us start. Dr. Ashok Punjabi, your take, anything regarding rivaroxaban or?
I think the incidence of GI disturbances are more commonly seen with the rivaroxaban. So they say people who have a GI, I don't know whether all of you agree with me. That's what I have seen some places. No, Navneet, you don't?
Dabigatran. I would say dabigatran has more of GI issue. If a patient has got dyspepsia, gastric problems, dabigatran is a drug probably which needs to be avoided. This is where rivaroxaban can probably be considered.
Bleeding, yes, but other symptoms, they say
No,
GI
even
symptoms.
dyspepsia, even for dyspepsia, they say dabigatran probably should be avoided. This is my take on that.
Okay.
Correct.
Right. And actually,
give to-
rivaroxaban also has some GI side effects more than other drug. I think if really GI is an issue, then
First is
apixaban stands
apixaban.
out.
First one would be apixaban. Rivaroxaban is
Correct.
the second
Yeah,
choice.
that's what I'm saying. Apixaban
Yeah,
stands
apixaban
out.
is definitely first choice.
Correct. Right.
Okay,
So-
I am going to, on this, I'll give you a live case. This is my own relative. So he is around 74. We've given him rivaroxaban once a day and tolerated it for a couple of years, developed some sudden loss of consciousness and some epilepsy and was put on anti-epileptic. Okay, this is in UK. And then he was okay for some time, then had a second episode, and then they stepped up the dose. And then suddenly one day he landed up with a massive unprovoked subdural hematoma and had to be rushed to the hospital. So this is a new sort of drug interaction that I have come across, and this is a practical case. And then what happens is, my question to all of you all is that after the subdural is evacuated, what next? What is your protocol of treating such a patient again?
Yes. Shall I answer this question, Bharat?
Yeah, go ahead, Navneet.
Yeah. Go ahead.
See, I mean, if you go by the literature, they say it's not an absolute contraindication to start them again. You wait for a certain amount of period, and if you feel the stroke risk is higher, even if a patient has had bleed and has bled, then the chances of recurrent bleed could be higher, but the stroke prevention is still better.
So Navneet, here, see, the whole question here is a spontaneous unprovoked versus a definite traumatic.
No, it's not a traumatic bleed. I'm talking of IC bleeds. Even IC bleeds, I can tell you that there is a data, there have been different analysis of different trials where they've shown that the recurrence rate of bleed could be higher as compared to other people.
Yes.
But when you see the stroke risk and the risk are definitely reduced. So they have a certain time frame for which you wait and then maybe start them on a smaller dose.
So yeah, so I'll tell you that.
A reversible agent like dabigatran, where you have an antidote to that.
Correct. So that is exactly my point, that one has to wait for after a big collection like this, which is evacuated, you have to wait for 4 to 6 weeks and then take your decision about your anticoagulation.
Correct.
Now, suppose he was on rivaroxaban. I would go for the same thing, that one is that you need an immediate reversal agent. 2 is probably go for the lower dose. And third, this is a question to you all, that if this is a background, would you then go in for a Watchman device, or would you put him on again NOAC?
Right. So the couple of issues now actually, Bharat, we have raised. One issue is whether you will go with the when to start repeat anticoagulation. I think literature says that you should take the help of the neurologist, neurosurgeon to decide on the CT scan report repeated CT scan reports when to start, whether it is on the 10th day, 15th day. 6 to 8 weeks may be a long duration according to me, Bharat. I think what I heard from the neurologist was anyway between 10 day to 21st day or something.
That is for a stroke.
That is for a stroke, not for a bleed.
Correct.
This is a large bleed where
Correct.
I'm
And as you said, see, couple of things we have to take into point whenever we give any NOAC or VKA also, that especially the role of addition of aspirin or NSAIDs. We don't have other drug food interactions with these drugs, but NSAIDs is something where is quite commonly given by general practitioner for some reason or the other. And patients also don't tell them that I am on a NOAC or something like that. And one may get a spontaneous bleed. That also is a possibility. As far as this LA appendage closure, it's an excellent point where patients who have such kind of bleeds or a bleeding episode or recurrent or something, then I think LA appendage closure is also an excellent point. Even in the other discussion when we were saying about that borderline case of female where the LA size is normal and there is a paroxysmal atrial fibrillation of EP ablation also is a good consideration.
Correct.
yeah.
Yeah, for such kind of patients, you know, where the other risk factors are not there and your paroxysmal atrial fibrillation is there and still the LA size is good enough not to have recurrence, then I think the atrial fibrillation ablation also is a good choice.
Yes.
Yeah.
Quite agree.
Right. Good, excellent point. So we discussed all that, bleeding versus ischemia, that is VKA versus NOACs, we all say that. Now the other thing is the last point is, when would you give 110 milligram of dabigatran or 15 milligram of rivaroxaban or 2.5 milligram of apixaban? All dosage which are less than the standard. So all the three drugs have different indications for giving this so-called low dose. So start, Dr. Navneet Kumar, take a call.
Yes. Steve, when it comes to apixaban, you use the ABC formula. The age of the patient, the body weight, and the creatinine. Creatinine more than 1.5, age, higher age, more than 80, body weight less than 60. You go on to 2.5. Again, as I said, creatinine 1.5. This is where it is. When you're going on to dabigatran, again, it is the creatinine part which helps you decide. Rivaroxaban, again, on the creatinine clearance. It helps you to decide as to how much you have to come down on. And the bleeding risk has to be assessed. If the bleeding risk is high, if your Hasbled score is high, then you tend to give a lower dose of dabigatran. From 150, you come down to 110. So the bleeding risk would be lower, though it's a non-inferior, not superior to VKA, but then yes, it's got its own role.
Right, absolutely. So, you know, that is one sort of niche where the Hasbled score is high and the Chatsworth score is high, where rivaroxaban possibly has a role in 20 milligram OD to prevent stroke and give you maximum benefit. That's the only place where it may have. But in this case, this female, the Hasbled score is hardly anything. So 150 milligram of dabigatran would be good. So Dr. Punjabi, your take on all this low dosage of all the three drugs?
I think Dr. Navneet has summarized the indication for low dose. Renal parameters are the most important things to be kept in mind, as renal excretion or dabigatran is 80% through the kidneys. It is lesser through for rivaroxaban and it is least through apixaban. So apixaban seems to be the safest even among the very, very low EGFR, even as low as 15 milligram per ml per minute. And so it can be used safely even in patients of dialysis as well as end-stage renal disease in the smaller dose of 2.5 milligram BID.
Excellent point. And suppose if the patient is also taking clopidogrel, then what, or aspirin, along with that, then what would be your take? Would you reduce the dose or would you continue the same dose? Dr. Anil Sharma, you can take that.
As Apixaban already described ABC criteria. As far as Dabigatran is concerned, normal dose is 150 milligram twice daily in younger patient. But in elderly with the renal function deteriorate, low dose is given, maybe 110 BD, and those who are like even EGFR more than 50, 150 milligram BD, 50 to 30, 110 BD, or maybe those who are more than 75 years of the age, even 75 milligram twice daily has been recommended. So that is about the doses.
Good.
And as far as this triple combination is concerned, aspirin in those high bleeding cases, it is recommended up to the 1 week. Very rare case, if those who are low bleeding, high risk, it can be given up to 3 months, but it should be preferably as low as possible. And after the 1 week, the preferred will be clopidogrel plus whatever usual dose of the oral anticoagulant.
Yeah, except Rivaroxaban, which is 15 milligram.
15,
Yeah,
1.5, yeah.
Pioneer trial.
15.
15 plus clopidogrel 75. And Apixaban is same 5 milligram BID with ABC criteria, and Dabigatran also is the same 75 plus 150 milligram BID. So Bharat, anything you want to add in this?
No, I think we've covered up everything. As soon shortly there will be data of Apixaban 2.5 even in patients undergoing dialysis.
Right.
Where you don't have to give warfarin there. You're safe with Apixaban, so that's fine.
And the last point in this COVID era, anything?
I'll interrupt there.
Yeah, go ahead.
Sorry, I'll interrupt you 1 minute. What Bharat has said, this dose, what Dr. Ashok Punjabi said of 2.5 can be given in patient with EGFR less than 15. It has not been universally approved. The FDA has allowed restricted use there, but the European side have not really allowed this kind of use. And as Bharat said, the data is yet to come. But in Dabigatran, basically less than 45 EGFR, the studies are not really, kind of supporting that. Rivaroxaban again has been given up to a creatinine clearance of 30, but some approvals have been there between 15 to 30 as well.
Yes, you're right.
And second, one more point I would like to suggest is just a practical point which just came to my mind as to how often you should be really monitoring the creatinine. And the guidelines suggested are that you see what your creatinine clearance is divided by 10. That is the frequency you should be really monitoring your creatinine levels.
Yeah, so that will be months.
Months, in terms of months.
Months, correct. Yeah.
50 divided by 10, every 5 months you should be monitoring your creatinine levels.
Creatinine levels, right.
I thought probably it's an important point that should be really highlighted.
Absolutely. No, it was nice of you to bring that point, because it's very easy to remember for practitioners also as to that first of all EGFR has to be repeated and at what frequency it has to be repeated. So I think, yeah, go ahead.
One last thing, consensus to, because I was little listening to Anil regarding triple therapy, AFib and stenting. So I think triple therapy for 1 week is okay. Maximum 1 month. If there is a complex anatomy and high ischemic rate, but I would not go for 3 months. Triple therapy maximum, the recommendation is up to 1 month. Although now, if you look at the data, and Navneet alluded to that also, that in 10% of the patient population that you used ticagrelor with Dabigatran. But increasingly now, we probably will just go with a combination of the potent ticagrelor with whatever NOAC that you select, rather than triple therapy.
Right. So I think, Bharat, 1 month also, I think the European people have said 1 month, if I'm not mistaken. But somebody also had suggested, let me try and find out, but I think the time is short, so I'll not go ahead. But it's all an individual call whether you want to do it. 1 month max is the
1 month
standard
max.
recommendation.
1 month is maximum. You
Right.
can do it for a week. After a week, you can go to the dual therapy.
Right.
If you're very worried about ischemia, then go for triple up to 1 month. But beyond that, it has to be only 2 agents.
Right, right. So we all agree with depending upon the bleeding risk and the ischemic risk which we have. So that's fine. I think, shall
Yeah.
we end now? If it is okay with
area,
all of you,
we missed one area.
please.
Is secondary stroke prevention in patient who already had a stroke.
Correct.
So I think just put just 1 or 2 points into that. If a patient has already had a stroke, you start them on antiplatelet, like most of the neurophysicians will start them on antiplatelets. Later on, you want to move them on to NOVAX. What is the time frame when you would like to move them on NOVAX? Is something that probably I would like to just give in 2 lines. See, you look at the NIHS score. Whether the patient has just had a TI, quickly recovered, you can start them as soon as possible. Otherwise, you follow what we call as Daniel's law. Depending on the score, less than 8, between 8 to 16, and more than 16, you decide whether to start them on 3 days, 6 days, and 12 days. You know, this is a kind of formula which has been kind of given. So that is the time frame. And if your scores are high, type of patients whom you think are going to require some intervention, some tracheostomies, so nasogastric intubations and all those stuff, in that case, you probably start them after 2 weeks. The American guidelines recommend 2 weeks. There are certain guidelines which may say less than that, maybe 10 days. 2 weeks is generally considered for people who have got high NIHSS score. In simple plain TIs, you can start them on day 1.
Right, right. I think this, I heard about this formula from the neurologist people. And the name, what is those criteria? I forgot that name.
NHISS.
NHISS, right.
Score. There's an 11-point score. Each one has got 4. So you work out the score. And this is how you are considering thrombolytic therapy in stroke, also depending on the risk of bleeding, depending on the score. So this
Right,
score is given, it's an app available. You can look at the score.
Good.
And depending on the score, you decide. If your scores are low, less than 8, then it's considered as a mild stroke. Between 8 to 16 is considered as a moderate, and more than 16 is considered as a severe stroke.
Severe stroke.
And the simplest way to remember, is like 1, 3, 6, and 12. Patient has got a TIA, day 1. Mild stroke, 3rd day. Moderate, 6th day. 12 days. It's like 3, 6, 12, easy to remember. There also, it's a simplified, it's not exactly the same figures, a little different is there. But for a remembrance, this is the simplest way it can be worked out, and that's what's called as Daniel's law. So in that 8, 16, and beyond 16, the score.
Fantastic. Good. So anybody else has to add anything for the sake so that everybody learns from each other? Bharat, Anil, Ashok?
Any aspect that area we have missed out, I just try to think, I just thought of this, probably we're missing out on this area.
No, good, good. Actually, as I said, I didn't try to remember this because I thought best thing is to refer to neurologist in-house. But it's good to remember and at least know that when to, go ahead.
Yeah,
Anil,
absolutely right. Yeah, I think this is what he's trying to show, correct?
Correct. Good. Excellent. Quick work.
Yeah.
Good job.
Yeah, efficacious drugs, safe drugs, but I would say confirm the diagnosis of hypertension, atrial fibrillation, or whatever risk factor before starting these medications.
Absolutely. Yeah, because they are lifelong. Actually, though I think Dr. Ashok Punjabi said that after 1 month or 2 months, you might think of stopping. But I do not think that the guidelines anywhere recommend stopping AFib unless you have a reversible cause.
Guideline says anything more than 30 seconds is atrial fibrillation. 30 seconds. But you have to document it.
I agree. No, Dr. Anil Sharma question was whether after 1 or 2 months and you do a Holter and you don't get atrial fibrillation, does it mean you will stop the drug? I don't think so.
No. You want to stop.
Unless you have a reversible cause, like
only one place post CABG. You can only place post CABG after 3 months. You can stop.
Correct. Yeah. So that we all know it's a temporary phenomenon. After 3 months, they recommend. But otherwise, you're right. Absolutely. Otherwise, it's not recommended. But though, as we all discussed, it's a very sensitive and practical dilemma which we face sometimes in practice. And I was about to ask actually on that point to Bharat, will you do a transesophageal before you start, will it make a difference? In such a patient where the transthoracic echo is normal, you have a documented AFib of 10 minutes. And now will you take the help of TE to decide whether you want to start anticoagulation or not?
No. The T and all that comes into picture when you're talking about cardioversion, or how much you want to anticoagulate before you want to do that. But here there is no recommendation to do a T prior to starting anticoagulation.
Okay, good.
PT, you are talking about this thing, anticoagulation in post-COVID duration.
Right.
Yeah. Important.
Yeah, so there actually I just wanted, whether one would prefer dabigatran, rivaroxaban or apixaban, and what dose and what duration. So just because this is COVID pandemic, I thought we will also take that point and for the benefit of viewers.
Correct. As of now, only rivaroxaban and apixaban have got mentioned.
Right.
I mean, this is what the paper and the data, these two drugs, along with the third drug, which is not available to us in India.
Yeah.
So at rivaroxaban 10 milligrams and apixaban 2.5 a day,
right,
for a period of 3 to 4 weeks.
If
you have pneumonia, then
only for hospitalized pneumonia 4 weeks.
4 weeks. Yeah. So that is the recommendation.
Right.
But when it comes to drug interactions,
it is not based on D-dimer levels.
No.
Hospitalized pneumonia.
But a lot of patients have very high D-dimer levels, 3,000, 4,000.
There are some places people are giving everybody, some places they are making cut off the D-dimers, that we are just keep on trying trial error method. But recommendation is by British Thoracic Society for 4 weeks of hospitalized pneumonia patients.
What is the role of D-dimer in that situation? Because there was a talk that if the D-dimer goes more than 3 times the baseline, if the jump is more than 3 times, then you need to be anticoagulating them, putting them on treatment. Because all patients are being given an enoxaparin 0.4 subcutaneous dose when they are hospitalized.
Anyway, those I think with hospitalized patient with pneumonia must be having all D-dimer high. Maybe I'm not aware in the depth.
The issue is actually so Jamshed Shunawala was who is our intensivist. He was mentioning that you can have thrombotic events even if the D-dimer is not elevated. So this COVID, one thing that you're sure about is that you are unsure about half of it.
Yes, correct.
So there is no direct correlation, but for all of us, I think in practice, D-dimer is elevated. It may become an off-label indication, but I guess
But I think on the safer side, we should anticoagulate all patients in ICCU 1 and all the high-risk patients in the wards also, and then at the time of discharge, give them oral NOAC.
Yeah.
Because the incidence of DVT is very high in these patients. Bharat, you remember we had a webinar on this, where we had talked about high incidence of DVT and all this stuff,
Yeah. So like VT just said, all of them in hospital have to receive it,
Yeah, and post-discharge also 4 to 6 weeks, especially those who have gone with a stormy course.
Oh yes, yeah. Chalo, I think we should.
Right, so we will end there. First, thank you all of you for this nice interaction which we had, and thanks Alkem for this opportunity. So please take care and stay safe. Like Anil was saying, that Delhi had bad experience as far as doctors are considered, and after second dose of vaccination, right, Anil? You see, that was the sad part of it. So Sandeep, can you close the session now?
Absolutely, sir. Absolutely. In fact, it's really a pleasure and to have all the legends on a same platform. In fact, the audience has really been enriched with the kind of discussion which is there, with all the clinical relevant experiences which you have shared, how to take care in this pandemic times also. And I certainly wish you all good of the health. Please take care of yourself and be safe. We will at Alkem will definitely serve your patients more better and better with our quality products like T-Sart, Dabiclot as well as Ticavic in coming days. So I wish you a good health. Be safe. Take care of yourself. Thank you so
Care,
much. Sir.
stay safe.
Thank you.
Bye
Jai
bye.
Hind,
See
Jai
you.
Maharashtra.
Thank you.
Yes, sir.
Thank you
Good
very
evening to
much.
all of you.
Thank you.
Thank you.
Bye
See you, VT, more often with bright light coming from behind you.
bye.
Ray of hope.
Great.
Ray of hope.
Ray of hope. You're right.
Bye, sir. Bye. Thank
That's
you
the
so much.
time to give ray of hope. Thank you
But
very much.
Okay.
Thank you so much.
Bye bye.
this telecast, only 8 of us are there, or there's a bigger
No,
audience?
no, sir. The count has almost touched 80. So I'll get back to you on the
No,
the
no,
list.
because
all the consulting physicians only we have invited across the city of Bombay.
Acha. I saw 8 participants, so I thought.
No, that
Only
we don't
among
have that
us.
access to that.
Bharat,
Yeah.
put one more zero.
Thank you. Bye bye.
Thank you so much, sir. Take
Bye.
care.
Jai Hind, Jai Maharashtra.
Jai Maharashtra.
Jai Maharashtra, sir.
चला चला काय हे ते ह्याच्यावर पाठ